Welcome to another lecture video on endocrine system. So on this video, I want to review the major endocrine organs that we have in the body. So we'll talk briefly about hypothalamus, pituitary gland, the two lobes of the pituitary gland, thyroid gland, parathyroid gland, adrenal gland, pancreas, pineal gland, thymus gland, gonads, and placenta. So let's get started. So I wanted to start by introducing hypothalamus. You remember that sometimes it's referred as a master gland in our body. And this is because hypothalamus really controls all other endocrine glands. So we see that it has very much that role of orchestrating and initiating these pathways. We discussed how hormones were multi-stepped pathways. And hypothalamus works closely on a gland, another endocrine gland that's located just underneath it, connected by a stalk. And this is going to be our pituitary gland. So pituitary gland receives messages from hypothalamus through two different pathways. First, through nerve connection. So there's literally neurons running from the hypothalamus to the pituitary gland. And that's especially going to be the posterior lobe of the pituitary gland. In addition to that, the second way how hypothalamus controls pituitary gland is through hormones. So again, we're seeing that one hormone triggers another hormone, which triggers a third hormone, and so on. And this hormonal control to the pituitary gland is especially relevant to the anterior pituitary gland portion. So let's unpack this a little bit more. And I wanted to talk first about hormones of the posterior pituitary gland. And we're going to start by talking about oxytocin and antidiuretic hormone. Well, oxytocin is an important hormone that plays a role through positive feedback mechanisms during the period of giving birth and also regulating lactation then on the post-birth period. This is an interesting mechanism because we're seeing that the process of birth and lactation were positive feedback mechanisms. So once the baby starts to come out, that triggers only more of the contraction of the uterine wall in response to the stretch of the uterine wall. So it has this additive effect, and that's why it was positive feedback. In terms of lactation, when we talked about the positive feedback mechanism with that, we saw as the baby suckled, the nipple milk surfaced, and that caused baby to suckle more of the nipple. So it's again this additive effect that we're seeing with the oxytocin for both of these purposes. The second hormone from the posterior pituitary that I want to highlight for us is our antidiuretic hormone, which is often abbreviated as ADH. An antidiuretic hormone does exactly what the name proposes. It makes us anti-urinate. So it brings down the amount of urine production. This brings us to talk about our first clinical example. And let's consider a clinical example of diabetes insipidus. And notice that this is very different from type 1 or type 2 diabetes mellitus. Here, what we're seeing is that the problem is with antidiuretic hormone, ADH. The body does not either make enough or respond to the ADH hormone. And in adults, this could be seen as passing large amounts of very pale urine, whereas on babies, obviously, we see this more of like as heavy and wet diapers, sometimes as bedwetting, trouble with sleeping, and so on. The treatment for diabetes insipidus is really to replace the ADH hormone or address the cause why it's not being released sufficiently. I also wanted to talk about the anterior pituitary hormones. So I've got a few that I want to mention here, and I want us to focus mainly on the human growth hormone. We'll discuss that in more detail through a couple of examples that I have lined up for us. But I do still want to mention other hormones. The other hormones that I want to mention are prolactin, which promotes lactation. And as you saw earlier on when we talked about the posterior pituitary hormones, we have two ways to regulate lactation. So that tells us that it's an important process to be regulated. And again, remember that prolactin would act through positive feedback mechanism. Another hormone from the anterior pituitary that I want to mention just briefly is our adrenocorticotropic hormone. This regulates the production of other hormones in the body, including cortisol and androgens. And we'll get to talk about those in a little bit. I also talk about thyroid-stimulating hormone. This controls the thyroid gland, which we will look at later. And again, notice this chain-like pathways that we're starting to see more and more emerging, that one hormone controls the next hormone, which controls the next hormone. This is really important as we try to tackle some of the clinical issues, or if we think of how drugs act. The final hormone that I wanted to mention from the anterior pituitary gland is going to be our follicle-stimulating hormone and luteinizing hormone. So both of these regulate female reproductive cycle, and hopefully we'll get a chance to look at that time when we get to that chapter. I do want to mention though that we do see these hormones also in men, but in much, much, much lower levels. But what I really want to do as we're talking about the anterior pituitary hormone is to look at the growth hormone. So let's zoom in to what we can learn about growth hormone a little bit. So human growth hormone drives the growth, and this is especially important that we have right amounts of this hormone during the critical periods. If we miss a critical period, a period during which that hormone should be present in right quantities, it's really hard to go afterwards and give extra hormone and hope to see that we would see those changes. So we have these windows of period during which these hormones need to be at the right levels. And some of the examples that I've highlighted here is an example of this in terms of pituitary dwarfism. So here we have too little growth hormone during childhood, and as a result, we don't get that sufficient growth. We also can have a gigantism. So we have too much growth hormone during the childhood, and now the individual grows too much. And if we talk about too little or too much, we do want to remember that these are not just subjective estimations, someone being big or someone being small. These do have medical consequences as well. For example, to take another example outside of our content, with the animals, we don't want animals to grow too fast. For example, dogs, if you feed them during the puppy period too much, they will grow so fast that their joints of the body can't keep up with that. On this picture that I'm presenting on this slide, we're seeing on the right-hand side, this individual exhibits the gigantism standing about 8 feet and 1 inch tall. Whereas the pituitary dwarf on the left-hand side is about 2 feet and 5.37 inches tall. So big difference simply based on whether the growth hormone was around in sufficient quantities during that critical period of growth. Another condition that I don't have a picture here, but I do want to mention, a condition known as acromegaly. This is when we have too much growth hormone produced as an adult. And this leads to abnormally large hands and feet and has a wide range of other symptoms. So in addition to those critical periods, we do have issues that can arise with too much hormones at different times of the life. So that's our pituitary gland. Let's move onwards. And next, I want to talk a little bit about the thyroid gland. So thyroid gland is located at the anterior neck below the larynx, so our voice box, and it produces two important hormones T4 and T3. And these hormones regulate our metabolism. So you can have too high level of these hormones or too little of these hormones. And we're going to see then in response to that subsequently, either overactive metabolic system or underactive metabolic system. And another thing that I'm highlighting on this slide is the rich blood supply around the thyroid gland. And remember, hormones traveled within the bloodstream, so we want to make sure that we have sufficient circulation around them. Let's look at some clinical examples as they relate to the thyroid gland. So I wanted to talk first about hypothyroidism. In case of hypo, we're seeing too little thyroid hormone. So we're going to see some clinical signs and symptoms as a consequence in response to the hypothyroidism. So here we're seeing on this slide a picture of a woman with an enlarged thyroid. So this is a condition called goiter. And what we see here is really the thyroid gland enlarging because of the lack of iodine. And this causes the swelling of the neck. There are small bulges or even large protrusions, and they can extend into the chest. Usually, goiter is painless, and if there are larger growth, this can cause discomfort and many other symptoms. What we end up seeing is that here in Western world, salt is typically iodized to prevent goiter from taking place. We do see this condition more of in the non-Western world where this is not a convention that takes place. I wanted to highlight another example of hypothyroidism. And again, remember, this is too little thyroid hormone. So let's have a look of cretinism. This is caused by severe deficiency of iodine during the pregnancy, and this could be due to mother's diet or certain drugs during the pregnancy. And this causes severe mental and physical retardation, and typically is characterized by intellectual disability, small stature, and thickening of facial features. And this results often in dwarfism during childhood. Let's have a look of one more example of hypothyroidism. And this is going to be myxedema. And this is a term used synonymously with severe hypothyroidism. However, this term is also used to describe a dermatological change that can occur in hypothyroidism and a paradoxical cases of hyperthyroidism. Your textbook describes the myxedema as a physical and mental sluggishness as a result of this. So now that we've had a look of hypothyroidism examples, I think it would be nice for us to have a look of one example of hyperthyroidism. So here we're seeing too much thyroid hormone around. And a good example of that would be our Graves' disease. Graves' disease results in increased metabolism, heat intolerance, rapid heartbeat, weight loss, and condition of these eyes bulging out. This is known as exophthalmos. So those were some clinical examples as it relates to the thyroid gland. Let's continue our journey of revising different endocrine glands and next have a look of parathyroid glands. And we see these small yellow glands within the thyroid gland, and like I said, they are known as our parathyroid glands. They produce parathyroid hormone. And this plays a really important role in our calcium homeostasis. Calcium plays part in most physiological processes around the body. So it is really something that we see quite a lot. Some of the roles that I can think of would include its role with the skeleton, not surprisingly, with the calcium, regulation, vitamin D activation, kidneys and urine production, intestines and digestion. But really for our purposes, I think that this is sufficient level of detail when it comes to the parathyroid gland and the parathyroid hormone. Let's look at adrenal glands. These are two small triangular shaped organs that sit on top of each kidney and produce hormones that control many important bodily functions. So for example, they help to regulate your metabolism, immune system, blood pressure, respond to stress, and other essential functions. And we can divide adrenal gland into two parts, especially when it comes to the study of the hormones that they produce. And the first one of these is going to be our cortex. So cortex was this outer layer. And there's going to be over 20 different hormones that cortex of adrenal gland produces. We will focus on the most important ones. So the first one that I want to mention is aldosterone. And this acts on kidneys and in ATPase, so energy production, blood pressure, plasma, and urine regulation as well. Cortisone and cortisol instead are hormones that are important in stress responses, also to do with metabolism and glucose regulation. And finally, from the cortical hormones, I do want to mention the androgens and estrogens. These give male versus female characteristics that we're going to see. In terms of the medulla and hormones secreted from these inner parts of the adrenal gland, let's have a look at epinephrine and norepinephrine. So these are chemicals that work together in the body's fight or flight responses, increasing heart rate, blood pressure, and blood sugar levels. So really preparing us either to deal with that danger by fighting it or by escaping that site. So now that we've had a look of adrenal gland and the two parts of that, the cortex and medulla, I think it would be good for us to talk some disorders just as an example. So let's have a look at adrenal cortex diseases. And the first one that I've mentioned here is going to be Addison's disease. This results from hyposecretion of all adrenal cortex hormones and is characterized by bronze, skin tone, muscle weakness, burnout, and susceptibility for infections. The second one that I mentioned here is our hyperaldosteronism. And this may result from adrenocorticotropic hormone, so ACTH releasing tumor. And in this case, excess water and sodium are retained, leading to high blood pressure and edema forming. Final example that I mentioned here, and that we're seeing a kind of illustration on that picture that I've also included, is going to be our Cushing's syndrome. And this results from a tumor in the middle of cortical area of the adrenal cortex. And some of the characteristic signs and symptoms traits that we see here are things like what's called moon face or buffalo hump on the upper back, and high blood pressure, hyperglycemia, weakening of bones, and also depression. So those were some examples of our disorders that relate to the cortex of hormones from the cortex of adrenal gland. Let's have a look at adrenal medulla disease. And the example that I've gotten here is our pecoroctomania. And this is a rare tumor that develops in the adrenal glands, causing them to produce too much epinephrine and norepinephrine. And the main treatment for this condition is a surgery to remove the tumor. So that was our adrenal medulla disease example. What I want to do next is continue our journey. We're next going to look at pancreas. So pancreas is particularly interesting for us because it actually is both endo and exocrine gland. So the exocrine role is really to produce the most complete digestive secretion that we see, known as pancreatic juice. Pancreatic juice breaks down food molecules and neutralizes the stomach acids in the small intestine. The endocrine role, which we're really interested in this context, is that pancreas manages our blood sugar levels through two important hormones, glucagon and insulin. These hormones are secreted from the islets of Langerhans. So this is the exocrine portion within the tissue of the pancreas. And in this picture, you can see this area around is then going to be the exocrine tissue that secreted pancreatic juice. Let's discuss these two hormones a little bit. So insulin is secreted from beta cells, and this really is stimulated by hyperglycemia, so having too much. And what we see is that the glucose then in response is being stored as glucogen. So really the purpose of insulin is to store that excessive sugar levels in our body. Whereas glucagon does kind of the opposite. It's secreted from alpha cells and it's stimulated by hypoglycemia, so having too little blood sugar. And here glucagon is broken down to glucose in the liver. So we're really releasing sugar for the body. And let's look at some of the disorders. And the disorders that I want us to look at are the two forms or two types of diabetes mellitus. And the type 1 is really the insulin-dependent diabetes mellitus. So here the individual is not producing enough insulin or is not responsive to insulin, and as a result they end up having to take insulin injections, and this is typically for the rest of their life. We often diagnose type 1 diabetes on younger patients, and then it's the rest of their life what they're going to be dealing with. Type 2 diabetes is instead non-insulin dependent diabetes mellitus. So here we're just seeing that the individual is not responding to insulin, and it's often late onset, so comes about later in life, and can be managed often quite greatly by lifestyle changes. So often we see that these patients, and once they do the lifestyle changes, they can get off the medication. I wanted to next talk about another endocrine gland known as pineal gland. And pineal gland is located deeper to the brain next to the third ventricle. And we also sometimes see it being called as pineal body, so don't get confused if you see these two expressions being used. So we saw the pineal gland during our sheep brain dissection. It's this little pea-sized gland deep in the brain, and it secreted hormone known as melatonin. And melatonin plays an important role in regulating our sleep-wake cycle or sleep-wake pattern. And you can find people who take additional melatonin as an over-the-counter produce, for example, managing signs and symptoms of jet lag. People who travel across the continent, across multiple time zones, might have hard time regulating their sleep-wake pattern during the transition period. So melatonin can be useful for that. We do also get it as a prescription product, obviously for more severe cases and uses. Next, I think we should look at our thymus. So thymus is often known as the part of the immune system where the T cells mature at, but it is also part of the endocrine system. So thymus makes and secretes hormone known as thymopoietin, and this hormone fuels the production of the T cells and tells the pituitary gland to release hormones. What's interesting about thymus, in my perspective as an anatomist, is that it shrinks and gets replaced by connective tissue and adipose tissue as one ages, but it still functions. And as we're approaching the end of our review, I want to talk about a few more structures. The second last is going to be our gonads. So gonads is just a general term for primary sex organs. In case of females, these are going to be our ovaries. And they're responsible for producing the egg, but for our purposes in endocrine system, especially the hormones that they also produce, estrogen and progesterone. In case of the males, the primary sex organ is going to be testis, and this produces the sperm, but also testosterone. And these hormones give us the secondary sexual characteristics as we enter to the puberty and start to see those changes taking place. And as the final endocrine structure that I wanted to talk about, I want to mention briefly placenta. Placenta is obviously a temporary structure that connects the developing baby in the mother's uterus to the maternal circulation. So there are important hormones that placenta produces during hormone, and we do want to note those play an important role in regulating the pregnancy. And this brings our little review of the main endocrine glands to an end. I think we've done particularly well of covering a lot of ground, and I appreciate, as always, you being part of these review sessions. I look forward to seeing you in subsequent content on this course. Until then, bye.